Hello.
Anyone from the audio video side, IT side?
Hello. Can you hear me? Hello.
Sorry, Dr. Tanu, like a slight confusion. I thought I sent from ID team, but it was sent from other mail.
Yeah, so yes.
You
So
got it now, no?
yes, I'm joined. Yeah,
Yeah. So on time only then. So we'll start the session.
yes.
I think today Dr. Kamlesh Tiwari has not joined there. Sir is busy with the Holi and he was traveling, I think so. Usually Dr. Kamlesh Tiwari will give the opening remarks of introductions. He's a Dean ICP. So without further wasting our time, we'll start the session 4 of this short certificate course in tropical medicines and infectious diseases. So today we are going to deal, actually we provided this course was happening on March 1st, but Dr. Tanu was slightly busy, so we rescheduled today. So we are doing it on 8th. So with this talk, we are completing the first set of 4 interactive talks is over. First provided by Dr. Professor Chandrasekhar. We discussed about how to approach infections in your practice. Then second thing is Dr. Uh, microbiologist discuss about clinical microbiologist infections approach. And third week, Dr. Priscilla Rupali discussed about how to approach a PUO. And today we are discussing about what antibiotic you need to select for different syndromes. So that's what Dr. Tanu is going to discuss today. And whatever questions, you please put it in the chat so that we can discuss it. Please, all the participants, you yourself mute it there and don't disturb during the talk. Last time, couple of disturbances happened, so please mute yourself. We are trying to mute yourself, but better you mute yourself. And whatever questions, if you want, you can put it in the chat box so that we can have a good timing for the question answer Q&A. We got 15 to 20 minutes. So without further ado, I'll ask Dr. Tanu Singhal to present the talk. Tanu knows no introduction because she's a very senior as well as familiar like a Heidi specialist from Mumbai. She's practicing right now Kokilaban, Durbai Ambani hospitals, and she's very familiar to most of the people, particularly the Fungal Infection Society Forum. She was very active and she has got a lot of publications on his credit. And she's a good friend of mine for last 10 to 15 years with the SITS as an executive committee member also. Open to you, Dr. Tanu.
Thank you, Dr. Suresh. And with that, can you stop sharing so that I can
I'll do
share
it.
my screen? Yeah.
Yeah.
So, sorry. Can you see my screen?
Yes.
Yes.
You are audible and slides are visible.
Okay. So today I'm going to be talking about the basics of antibiotic selection in practice. And actually my talk is assuming that you have done some revision of your pharmacology and microbiology. However, if you have any kind of questions, even however basic they may be, please don't hesitate to ask me at the end of my presentation. I hope to finish in about 45 minutes so that, we'll have enough time for interaction after this. Now, it's, I think, why do we need to select the right antibiotic? I think the uppermost thing in our, just 1 minute, please. Sorry. Hello, I'm busy in a meeting. Please. I'm busy. Native direct. Yeah. Yeah. The rights, I mean, as a physician, the right selection of antibiotic is needed to ensure that our patient gets well. That is the thing which is uppermost in our mind because we want our patient to get well. But at the same time, we want it to happen with the minimum adverse effect. We don't want to cause the patient any harm. At the same time, we want our cost to be kept low. And then we also have an important, kind of responsibility that we don't want antimicrobial resistance to increase. And all these are actually termed antimicrobial stewardship. That means we give the right antibiotic at the right time, at the right dose for the right duration. So this is called as antimicrobial stewardship. That means to select the right antibiotic. And that is exactly what we are going to discuss in today's presentation. Now, the first question that we need to ask is an antibiotic really necessary? Because most fevers that we see in the outpatient practice are due to viral infections. And the common viral causes of fever in OPD practice are a viral respiratory tract infection. In fact, there are certain studies which say that 70% of the fevers which come to the OPD are due to either rhinovirus, influenza, human metapneumovirus, parainfluenza, etc. Most of the patients, either in pediatrics or in adult, come due to viral sore throat. And unfortunately, maximum abuse of antibiotics happens here. I find it very strange that even doctors actually prescribe antibiotics to themselves for these infections. They take azithromycin, which is a long time favorite. And these infections don't need antibiotics. The second common infection is diarrhea. In fact, below 5, most of the diarrhea is due to viral causes and doesn't need antibiotics. The third is tropical fevers like dengue and chikungunya in the monsoon season. These don't need antibiotics. And then exanthematous illnesses like hand, foot, mouth disease, chickenpox. Now, for diseases like viral URTIs, viral diarrhea, chickenpox, hand, foot, mouth disease, only a clinical diagnosis is enough. You don't need to do lab tests. But yes, for dengue, chikungunya, you need to do lab tests. And these things don't need antibiotics. And antibiotics do not prevent bacterial superinfection. That means if you are having a sore throat, cold, and cough, if you take antibiotics, you will not prevent the development of a sinusitis or an otitis media. So that is an important thing which you need to understand. And if we practice antimicrobial stewardship here, we will reduce the development of antibiotic resistance. Now, let us assume that we have taken care of all this and we have finally decided that our patient needs antibiotics. Then, antibiotic therapy can be either empiric, or it can be definitive or targeted, or it can be prophylactic. And we will discuss these three types of antibiotic therapy in today's lecture, one by one. So, what do you mean by empiric antibiotic therapy? Empiric antibiotic therapy is when the pathogen is not known. We don't know whether our infection is caused by pneumococcus or staph or salmonella, and it is based on the clinical syndrome. And when the investigation results are pending or not been sent. Like, for example, that you see a patient who comes to you with high fever and he has a severe headache, he has a thick, purulent discharge and he has maxillary tenderness. So you know that this patient has a sinusitis. Now, in this patient, you are not going to be sending any kind of test to confirm the diagnosis. So here the antibiotic therapy that you will be practicing is called empiric antibiotic therapy. Now let us take another situation. You have a patient who comes to you with fever, which has been increasing over the past 4 to 5 days, and he has a toxic look, he has a coated tongue, and probably dealing with a case of typhoid fever. You send a blood culture, but you are not waiting for the results of the blood culture to come back, and you have started this patient on an antibiotic appropriate for typhoid fever. So this is also called empiric antibiotic therapy. So both these cases, you are giving empiric antibiotic therapy. Now, how do you choose an empiric antibiotic? So the choice of an empiric antibiotic depends on many things. First, it depends on what is the likely pathogen. So, for example, if you see a patient who comes to you with a skin infection, like he has, like, let's say, a gluteal abscess, then when you see that patient with a gluteal abscess, automatically you know from your knowledge of your pathology or microbiology that this patient will have, let's say, a staph, probably, or a staphylococcus infection. Now, then the next thing which comes to your mind, that what is the likely resistance pattern in this staph? So from your knowledge of microbiology, you know that maybe 20 to 30% of this staff is MRSA, the rest is going to be MSSA. Now, then the third, so you are going to choose an antibiotic which will cover your staph aureus. Now, the next question which comes to your mind is that am I going to start him on an MSSA antibiotic or am I going to cover MRSA also? Now, that decision depends on the severity of the disease. So now suppose this patient comes to you in the OPD, then and he's otherwise okay. So you will probably start him only on an anti-MSSA antibiotic because you know that if this patient doesn't get well in 2 to 3 days, you will then add an anti-MRSA cover. On the other hand, if this patient comes to you in the ICU, in septic shock, in maybe in toxic shock, then you know that you are going to start this patient on both an MSSA and an MRSA cover because you don't have time to upgrade therapy. So you don't want to go wrong with your antibiotic choice. And hence, the severity of the disease influences your choice of antibiotic. Because in a stable patient, you will go narrow spectrum. In a sick patient, you will go broad spectrum. Then another factor which influences your choice of antibiotic is the site of infection because obviously you will use an antibiotic which goes into that site. Suppose you have a patient who comes to you with a urinary tract infection. Now, obviously, you will not use an antibiotic which doesn't go into the urinary tract. Like you will not use, let's say, chloramphenicol. You will not use, of course, chloramphenicol, we don't use any which ways. You will not use tigecycline, which doesn't go into the urinary tract. Now, if you have a patient who comes to you with a meningitis, you will not use an antibiotic which doesn't go across the blood-brain barrier. Another factor which influences the choice of the antibiotic is the host comorbidity. That means if you have a patient who comes to you who has renal impairment or he has chronic kidney disease, you will not use a nephrotoxic drug like amikacin because if you know that if you use a drug like this, you are going to cause further renal damage. If you have a patient who is heavily immunocompromised, then you will be very careful with your choice of antibiotics because you know you are going to use a more broad spectrum antibiotic because you know that this patient will probably have a more, he can have multiple pathogens which can cause the same clinical syndrome. And if this patient is very neutropenic, you know that the patient's neutrophils are not going to protect him. So, therefore, your choice of antibiotics depends on so many factors. And then after that, you will choose a narrow spectrum drug that will do the job. But remember that when you are faced with a situation, you don't always have to do the mental exercise of all this. You can just follow the guidelines for treatment because the people who have formulated these guidelines have already done these exercise and therefore follow the guidelines. And there is also one very important thing that I want to tell you is that before you start empiric antibiotic therapy, always send cultures if indicated. But you don't always have to send cultures. So, for example, if you're dealing with acute otitis media, you are not going to send cultures. If you're dealing with sinusitis, you're not going to send cultures. But yes, if you're thinking of typhoid fever, you are going to send blood cultures for the patient. So then let us discuss what antibiotics we are going to use for particular clinical syndromes in the OPD and in the IPD. Now, some empiric therapy in OPD practice. Now, let us consider a syndrome of exudative tonsillitis. That means a patient comes to you with fever, sore throat. And when you examine the throat, you find that there are pus points on the tonsils. He has tender cervical nodes and there is no cold, there is no cough, then you know that this patient could be having a group A beta hemolytic strep infection. Of course, this could also be seen in infectious mononucleosis. It could be seen in adenovirus, but this could be group A beta hemolytic strep. So in this case, you don't really need to do a throat swab culture and you can start this patient on amoxicillin. You will not use co-amoxiclav. Why you won't use co-amoxiclav? Because we know that group A beta hemolytic strep is uniformly sensitive to penicillin. And if you use co-amoxiclav here, you will be actually destroying the GI flora of the patient, which has anaerobic and gram-negative flora, and you will cause more resistance. This patient may get colonized with ESBL pathogens. So remember that important principle. Try and use the narrowest spectrum antibiotic, which will do the job. And one very important thing which you have to tell the patient is that give this antibiotic for 10 days, because if you use this antibiotic for less than 10 days, then the patient will have a relapse of the tonsillitis, and also the patient will not get protected against rheumatic fever. Now, let us come to another situation. If you think your patient has either a bacterial sinusitis or otitis media, then again go back to what could be causing this syndrome. You know that this could be caused by pneumococcus or Moraxella or Haemophilus influenzae, because these are the three pathogens which cause sinusitis or otitis media. Here, you can use either amoxicillin, but you could also consider co-amoxiclav, because we know that 90% of Moraxella and 30 to 40% of Haemophilus produce beta lactamase. And therefore, if a patient is very sick, you might use comoxiclav. Now, many people use azithromycin for patients with bacterial upper respiratory tract infections, but that is not the right choice. Why? Because 30 to 40% of your pneumococcus and your Moraxella, Haemophilus, and group A beta hemolytic strep are resistant to azithromycin. And then people say that I had a sore throat, I took azithromycin and I got better. And the reason they got better is because it was actually a viral sore throat and antibiotics were not indicated. Remember, cefixime is not a good drug for any bacterial upper respiratory tract infection, because cefixime does not cover pneumococcus, which is a gram-positive pathogen. So remember, most of the upper respiratory tract infections are viral and they don't need antibiotics. But if you are faced with a bacterial upper respiratory tract infection, then your choice is either amoxicillin or coamoxiclav. Even the third generation cephalosporins like cefpodoxime are not good antibiotics for bacterial upper respiratory tract infections, because they don't achieve good levels in this area. Now coming to a pneumonia, that means a community-acquired pneumonia, which is who is not so sick and who can be treated on an outpatient basis. Now here you are dealing with either pneumococcus or an atypical pathogen like mycoplasma. So you can use either amoxicillin or maybe a cefuroxime or coamoxiclav, but you have to use an atypical cover along with it, either azithromycin or doxycycline. And in the current situation, we are seeing a lot of mycoplasma which are becoming resistant to macrolide, primarily because of increasing macrolide resistance because of widespread use of azithromycin. So you might want to use doxycycline along with amoxicillin for a community-acquired pneumonia. Then what about pyoderma? Now, suppose you want to use you can use topical therapy with, fusidic acid, etc. But if you want to use systemic therapy, then you're either thinking of Staph aureus or group A beta hemolytic strep. So the first generation cephalosporins like cephalexins are the drug of choice. And again, one should not use coamoxiclav here, because as I said, coamoxiclav is very broad spectrum and it kills your anaerobes and your gram-negative flora in your gastrointestinal tract. Again, why not an MRSA cover up front? Because again, you might ask that you can have MRSA, Staph aureus, which is MRSA. And the reason I said is because these are stable patients. If your patient does not improve with cephalexin, you can always send a culture. And if it is MRSA, then you can give an anti-MRSA drug. You don't need to use an upfront MRSA cover in stable patients. What about a patient who comes with you with cystitis? And you know now that most of this cystitis is due to E. coli. And we know that a lot of our E. coli in the community are producing extended spectrum beta lactamases, drugs which destroy your cephalosporins. So in this situation, the drugs of choice are trimethoprim sulfamethoxazole or nitrofurantoin. These drugs work well against ESBL pathogens as well. And then what about febrile UTI? That means a patient who's not really sick, not an elderly patient who needs to be admitted with a UTI, but a patient who's otherwise healthy, who's having fever and urinary tract symptoms. Again, These patients are usually having E. coli, which is producing ESBL, and here you can use either TMP SMX or cefixime clavulanic acid. Unfortunately, ciprofloxacin is not a good drug to give in these patients because 90% of our E. coli isolates are producing beta lactamase, are actually resistant to ciprofloxacin, and 40 to 60% of them are producing beta lactamase, and cefixime does not work in these things. And remember, if you have a patient who looks toxic with a urinary tract infection, that patient should better be admitted to the hospital. Then we have another situation where you have a patient who comes to you with what looks like enteric fever, as I discussed about before, with fever. I think please mute yourself.
Please mute.
Everyone,
We told them
please
earlier,
mute
please mute.
yourself. So if you have a situation where a patient comes to you with fever and the patient's fever is not getting better and you have toxic low coated tongue, you're thinking of typhoid, the counts are normal, CRP is high, you've sent blood cultures, you know that in our country, 90% of our isolates are resistant to quinolones. So in this situation, you will use either cefixime or azithromycin. Now, another very important point here, that the cefixime that you use here has to be high dose cefixime. You can't use 200 milligram twice a day. You have to use 600 milligram twice a day. And the azithromycin which you use has to be 1 gram once a day. And there's no need to use combination therapy here. Many people use combination of cefixime ofloxacin, and that is completely irrational therapy because the oflox does not work against our Salmonella typhi. So I have listed out some common situations in OPD practice where you have to use antibiotics. Now, there are some other important things which you have to follow when you're choosing an antibiotic in OPD practice. Pay attention to the brand, because unfortunately in our country, there are so many pharmaceutical companies where the drug may not be good enough. You have to counsel your patient about adherence and compliance. Tell them, for example, if it is streptococcal sore throat, give antibiotics for 10 days. Tell them about food interactions. That is extremely important. For example, azithromycin has to be taken empty stomach. Clarithromycin has to be taken with food. Warn them about the side effects, because if you don't tell them about side effects, they will default on therapy. Tell them if you're giving clavulanic acid, there may be some diarrhea. You should not be worried about it. If you're prescribing them comoxiclav, and that is, as a pediatrician, I know if you're giving the syrup, tell them that once you reconstitute the syrup, it has to be kept in the refrigerator. Warn them what will happen if the course is not completed. And also counsel them about symptomatic therapy, because if you don't tell them that how to manage fever and other symptoms like cough, then they may not follow your antibiotic prescription. So remember that treatment of the illness is a complete package, and it is not just the antibiotic alone. So now from OPD therapy, we move to inpatients, because we can have serious infections where the patient needs to be admitted. Now let us come to a patient who comes to you with what looks like bacterial meningitis. The patient has fever, the patient has neck stiffness. Now you have sent blood cultures, you have done a lumbar puncture, and the most important pathogen here is pneumococcus. And we know in our country, there is rising penicillin and ceftriaxone resistance. So you are going to start this patient on ceftriaxone and vancomycin, and not just ceftriaxone alone. Of course, once you have your cultures back and your susceptibility, and you find that the isolate is sensitive to ceftriaxone, you can drop the vancomycin, and we will talk about definitive therapy later. What about pneumonia? If your patient gets admitted to the hospital with a pneumonia, you know it could be pneumococcus, it could be atypical pathogens. So you will be giving this patient ceftriaxone and doxycycline.
Mute. Please mute everybody.
you will be giving this patient their ceftriaxone and doxycycline. Now, here I want to tell you why it is important to look at Indian guidelines and not the international guidelines. Because if you look at international guidelines, they all talk about using levofloxacin. But you know, in India, TB presents as a community acquired pneumonia. And in community acquired pneumonia, if you use levofloxacin and it's TB, you'll mask TB. Therefore, please do not use levofloxacin as a cover for atypical pneumonia in India. If you have to use an atypical cover, use doxycycline. Then, what about a patient who has a pneumonia and who has a comorbidity? Let's say he has COPD, or who's alcoholic, or who's a heavy diabetic, or who has some other immunocompromised state. Now, in this situation, you have pneumococcus, you have atypical pathogens, and you also have Pseudomonas or Klebsiella coming in. In such a situation, the beta-lactam that you choose will have to be either piptase or meropenem along with doxycycline. If such a patient pneumonia is necrotizing, that means you see pneumatoceles, you see cavitation, then you also have to worry about Staph aureus or MRSA. Now, in this situation, you will also have to add an anti-MRSA therapy to the empiric regime. You will either have to add vancomycin or teicoplanin, or you can use a beta-lactam along with levonadifloxacin, because this levonadifloxacin is a drug which covers atypical and it also covers both MSSA and MRSA well enough. And suppose you are dealing with a pneumonia in a patient in the influenza season, then you have to also think of a influenza, and you will have to empirically start oseltamivir till the patient's results come back. So if you look at this table, again and again, we are reiterating the same thing, that first look at the clinical syndrome, think of the pathogens, think of the resistance pattern, and then choose your antibiotic based on the severity of the illness, and also look at the host comorbidities. Now, suppose you have a patient who comes to you with a bone and joint infection. Now, if you have a bone and joint infection, as I said, you think of Staph aureus. Now, if the patient is sick, then you have to cover your MSSA and MRSA till your blood cultures and till your bone and joint fluid cultures come back. So again, you have to start the patient on an anti-MSSA drug, which is either cloxacillin or cefazolin, and an MRSA drug, which is vancomycin or teicoplanin. So again, as I said, your empiric therapy in a sick patient will have to cover both the possibilities. Another situation in an inpatient or a patient who comes to you in an emergency is a patient who comes to you with sepsis with no focus. That means he has come to you with multi-organ dysfunction, maybe in shock, and you can't find a focus. Now, this could be pneumococcus, this could be a gram-negative sepsis, and in the monsoon season, it could also be rickettsia or leptospira. So here, you would maybe give ceftriaxone or meropenem along with doxycycline, because especially in South India or in Vellore, it could be scrub typhus. So therefore, you would have to add doxycycline to the empiric regimen, because in these patients, once your reports come back, you have to, because you know the golden hour of sepsis, isn't it? The rule is that you have to give the right therapy, because if you delay the right therapy, you may lose the patient. Now, what about a patient who gets admitted with pyelonephritis in the ward? Your patient has a suspected UTI and you don't know the bug yet, and you think it's E. coli or Klebsiella, and you know most of these are ESBL. So here you will start either piperacillin tazobactam or cefoperazone sulbactam, because these are drugs which take care of ESBL pathogens. But what about if this patient is in sepsis or in septic shock? Now we know that for severe ESBL infections, you have to use meropenem, because there was this trial which was called as the Merino trial, which compared patients with serious ESBL infections who were given meropenem versus piptaz, and the mortality was lower with meropenem. So remember, if you have a serious either a urinary tract infection or an intra-abdominal infection where you're suspecting a ESBL pathogen, you have to choose meropenem instead of a BL-BLI combination. Now, what about an acute appendicitis? Acute appendicitis, now we are moving to the abdomen. We are moving to an abdominal sepsis, which can be appendicitis, which again, you know your pathogens are E. coli and anaerobes. You can use ceftriaxone and metronidazole, but the problem with this is that it's not covering ESBL, so you can give piptazo. Now, remember that when you are giving a drug like piperacillin tazobactam, it is covering your anaerobes also. So when you use piptazo, you don't need to add metronidazole to the regime, and you will see so many prescriptions by surgeons that when they give piptazo, they also give metronidazole. That is not needed. What about liver abscess? Another common infection. Now, liver abscess can be due to number of pathogens. It can be due to staph, it can be due to E. coli, it can be due to Klebsiella, it can be due to anaerobes, it can be due to even Entamoeba histolytica. So till you get your pathogen, you will give piptase or meropenem because this drug will cover most of your bacterial pathogens, and here you will give metronidazole. And the purpose of giving metronidazole here is not to cover your anaerobes, but to cover Entamoeba histolytica. Now, what about a perforation peritonitis? That means a person comes with intra-abdominal sepsis due to a intestinal perforation. Here, you can have a zoo of pathogens. You can have GNB, you can have anaerobes, you can have enterococcus, you can even have fungi. So you have to use, again, a BLBLI or a carbapenem. And again, as I said, you will not give metronidazole because these drugs cover anaerobes. Biliary sepsis, again, you have mainly gram-negative pathogens, and therefore, again, you will use either a BLBLI or a carbapenem depending on the severity of sepsis. Now, we move from community-acquired infections to hospital-acquired infections. Now, when we talk about hospital-acquired infections, we again go through the same discussion. What are the likely pathogens for hospital-acquired infections in India? It's mostly gram-negative pathogens. E. coli, Klebsiella, Pseudomonas acinetobacter. Again, MRSA is not common, and Candida can be there in patients with risk factors. And therefore, the local antibiogram is very important when you choose an antibiotic for a healthcare infection, because for every unit, there is a different pathogen causing the infection. Now, when we look at the likely resistance, it is dependent on that ICU again. But broadly speaking, in India, most of the pathogens, gram-negative pathogens which cause hospital-acquired infections are very resistant. 80% are ESBL producing and 50% are carbapenem resistant. Severity again is generally very high. Most of these patients are really sick. Most of them are in the ICU. Most of them have organ dysfunction. And therefore, you have to get your antibiotic right. The site of infection, again, makes a difference. So if your hospital-acquired infection is a COTI, you have to give an antibiotic which has good urinary penetration, etc. And again, most of these patients who get a hospital-acquired infection have a lot of comorbidities, like they have renal or hepatic dysfunction, again, which influences your choice of antibiotic. So if I was speaking for my hospital, where most of the pathogens which cause hospital-acquired infections are either Klebsiella or Acinetobacter. If a patient in my ICU falls sick, then we generally would use polymyxin B based therapy with tigecycline with an echinocandin, because that's what we are facing in our hospital. So you have to ask your intensivist or your microbiologist what is the cause of their infections. Now, when you start empiric therapy, again, at 48 to 72 hours, you have to modify your therapy because it will be guided by your results of investigations and clinical progress, because you have selected a particular treatment, and maybe at 48 to 72 hours, you may stop antibiotics because you may have a non-bacterial cause. Let's say you have a patient with fever, you think it is typhoid, and you have sent the investigations, and at 48 hours you get your dengue positive, then you know that this is dengue and this is not typhoid. So you're going to stop antibiotics. People sometimes have the concept that if you have started antibiotics, you have to complete the course. Completion of that course is important if it was an infection to begin with. If it was not a bacterial infection, you don't have to complete the course. If it is indeed a bacterial infection and the patient is better, then you have to complete the course of antibiotics. If your cultures are positive, then you have to modify the antibiotics as per the cultures. And we are going to discuss definitive therapy in the next section. And the most difficult part is that your cultures are negative and your patient is deteriorating. That is the most difficult part of antibiotic selection. And that is when you have to reevaluate the patient, because you have probably not made the right diagnosis and you have to really reevaluate the patient. So from empiric therapy, now we move to targeted therapy, which is on the basis of the results of microbiologic investigations. Often it is based on cultures, but sometimes it is also based on the results of serologic tests and molecular tests, like a PCR test, like you have done a throat swab or a nasopharyngeal swab and you find that you have detected some virus like flu, and then you start to seltamivir, or you have done a CSF meningoencephalitis panel and you found pneumococcus there. But remember that you should not do targeted therapy on the basis of your poor tests like Vidal or typhi.igm. Like you had a patient with fever and the typhi.igm is positive, and you have thought that this is enteric fever because it may not be the true positive test. Now, another point which I wanted to make is that when you do definitive therapy based on cultures, first you should be sure that the culture is a true infection or is it contamination or colonization. Let's say you have sent a blood culture and your blood culture shows cons or Bacillus cereus or Burkholderia cepacia. It may be contamination. And if you are going to treat your patient on the basis of that culture, it may be wrong. Similarly, if your urine culture is positive, you must be sure that the urine culture actually represents a UTI, because it may just represent contamination or colonization or asymptomatic bacteriuria. Similarly, if you have an endotracheal culture which is positive, or a drain culture which is positive, or an open wound culture which is positive, you must make sure that that culture actually represents infection and not colonization. Because if you start treating these cultures, you may not be correct and you may be treating colonization. But suppose you decide that the organism which you have grown on culture is relevant, then you have to look at the susceptibility. And I think you've already had a lecture on how to look at susceptibility, and you look at susceptibility by various methods like disk diffusion, dilution methods, and gradient diffusion methods like E-strip. And by antibiotic susceptibility testing, you classify organisms as sensitive, resistant, and intermediate, and you compare the zone or MIC to breakpoints. And there is one very important concept which I want to tell you, that when an organism is pronounced sensitive, then you know that the chances of therapeutic success are 95%. But when an organism is pronounced as resistant, the chances of therapeutic success are low, but not zero, but they are 60%. So this is called as the 60-90 rule. So that is the reason why what happens is that suppose you have sent a culture and you have started an antibiotic, and then after 48 hours, your culture comes back and you have found that the organism is resistant to the antibiotic that you have started, but the patient is better. So that is explained by the 60-90 rule. That means that even if the organism is resistant, sometimes in vivo the antibiotic works. This is because of the 60-90 rule, that despite the organism being resistant, the antibiotic works. But in most of these situations, sometimes you will find that later you may get therapeutic failure. So if the patient is really sick, you may still want to change the antibiotic to one to which the organism is sensitive. Now, another important concept which I want to tell you is that sometimes it is not important to just look at sensitive or resistant, but you should also look at whether it is the MIC and how much is the MIC below the break point. Now, most labs don't give you the break point, but you can look at certain tables which are available on the net, or you even have a calculator which you can download on Android phones, though not on iPhones, and you look at how much is the MIC below the breakpoint, because lower is the MIC below the breakpoint, greater is the chance of success. And if the MIC of the organism is just at the breakpoint, you may have to use a higher dose. And this is the breakpoint MIC calculator, which you can download on an Android phone, and you can write the name of the bacterium and the antibiotic, and it will tell you what is the sensitive breakpoint and the resistance breakpoint. So, for example, for enterobacterials, the ceftriaxone sensitivity breakpoint is 1 and the resistance breakpoint is 2. It is in Italian, but you can still understand it. Now, let me give you some examples because we just have about 5 to 10 minutes left. Suppose you have grown Staph aureus. Then you look at the sensitivity. Now, if you look at oxacillin first, it says that oxacillin is sensitive. Now you look that there are so many other antibiotics are also sensitive, like Cipro is sensitive, Levo is sensitive, but you must understand that for every bacteria, there is a certain antibiotic which you have to choose. Even though Cipro is sensitive, you can't use ciprofloxacin for treatment. So for every bacteria, there is an antibiotic which is best used for treatment. That means you either use cloxacillin or cefazolin. Now, you cannot use Vanco or Tico for treatment. And if you look at this susceptibility report, the lab has not given Vanco Tico susceptibility. And this is an example of stewardship. That means the lab has not given these antibiotics because the lab doesn't want the clinicians to use these antibiotics for treatment. So while there may be so many antibiotics reported as sensitive, for each bacteria, there is a particular antibiotic to which should be used for treatment. And again, linezolid and all should not be used for treatment. Now, this is another Staph aureus. And here, if you look at oxacillin, oxacillin is resistant. So this is an MRSA, and MRSA is best treated by vancomycin or by teicoplanin. And I'm not going into further details about treatment, but this is just for you to recognize that when you look at Staph aureus, look at oxacillin, and if oxacillin is resistant, it means it's an MRSA. Now, this is a gram-negative infection. And if you look at E. coli, if you look at ceftriaxone, and if ceftriaxone is resistant, it means it is ESBL. And here, if you look at meropenem, is sensitive. And piptaz is also sensitive. So this is an ESBL pathogen, and you have to choose between either a BLBLI or carbapenem. Now, as I discussed earlier, how will you choose? If it is a severe infection, you will choose a carbapenem. And if the patient is not very sick, you can choose a BLBLI. Now, this is another infection, which is Klebsiella. And if you look at this sensitivity report, you will find that carbapenems are resistant. So this is a carbapenem resistant Klebsiella. And now we are moving away from treatment with colistin to ceftazidime, avibactam based therapy. Now, there are some other things which you have to remember in inpatient practice. That means you have to give loading doses of antibiotics. You have to adjust doses for renal dysfunction. You have to give instructions to the nurses about administration of the antibiotic, whether it has to be given over 30 minutes or 2 hours. You have to look at drug interactions. You have to monitor for drug adverse effects, and you have to limit duration of therapy to 7 days for most infections, with the exception of Staph aureus in Canada, where 2 weeks are required. And the last bit of my presentation is about prophylactic antibiotic therapy, because we have discussed empiric antibiotics, we have discussed definitive therapy. And the third bit is prophylactic antibiotics. Now, prophylactic antibiotics are useful only in limited and specific situations, because if you are going to use prophylactic antibiotics, it will only lead to emergence of resistance. So only the main requirement of prophylactic antibiotic is when there is a host who is at increased risk to get an infection with a particular organism. And this is only for a limited period of time in a particular setting. So some of the examples of prophylactic therapy, which you know very well, is like prophylaxis against rheumatic fever. So you give it for, let's say, maybe up to 18 years if the patient didn't have carditis, or up to 35 years if the patient had carditis, or you give infective endocarditis prophylaxis before dental procedures, or the most important prophylaxis which we see is surgical prophylaxis, which ideally should be only a single dose before a surgical incision of cefuroxime or cefazolin. Then penicillin prophylaxis in asplenia, chemoprophylaxis for recurrent UTI, chemoprophylaxis for malaria in travelers, and chemoprophylaxis for opportunistic infections in HIV. So these are some very, very definite indications for prophylactic therapy. And apart from that, you should not be practicing any kind of prophylactic therapy. Like sometimes, people give prophylactic therapy. Oh, this patient has a central line, let's give prophylaxis. Or this patient has an indwelling drain, let's give prophylaxis. So remember, prophylaxis never prevents infection. If you want to prevent infections, you have to go do good infection control. So finally, I would like to end my presentation by saying that antibiotics are a precious non-renewable resource. Remember, this is a non-renewable resource. We need to use them wisely. First, we need to think whether antibiotics are actually needed for a fever patient. Because as I said, most of the fevers are viral. You just give symptomatic paracetamol, that's it. If yes, then first you decide whether any lab tests or cultures should be sent. Because if the cultures have to be sent, they should be sent before giving antibiotics. Then you choose antibiotics wisely based on the likely pathogen, likely resistance pattern, severity of illness, site of infection, and host comorbidities. Then reassess the choice at 48 hours, and at 48 hours, optimize your therapy, either stop your antibiotics, optimize, escalate, de escalate, and then finally give them for an appropriate duration. I think with that, I end my presentation and turn it over to the moderator. Thank you so much.
Thank you, Dr. Tanu, for a wonderful presentations. Already a couple of questions as posted in the chat box. I'll read out for you. What is the role of procalcitonin in differentiating viral pneumonia and bacterial pneumonia?
Not too much.
Not much.
Yes, I think it's, as I said, in our country, I mean, if you are dealing with a pneumonia, it's much better to start antibiotics empirically, because I think there are many other places where you can do antimicrobial stewardship. So if you have a patient who comes to you with a community acquired pneumonia, I think it is better to start basic antibiotics.
Then the same person is asking, what is the role of procalcitonin in sepsis? You are saying for a pneumonia community acquired, it's not very limited role. What about sepsis? He is asking.
So I think now it is very clear that procalcitonin does not have a role really in differentiating between viral and bacterial sepsis. The main role of procalcitonin is in limiting the duration of antibiotics. That is, you can decide if your procalcitonin comes down to maybe 80% of the peak or something, then you can stop therapy. I think that's where we are really using procal. See, because you can understand that if your patient comes very sick to the hospital, you cannot withhold antibiotics. If your patient comes with multi-organ dysfunction and sepsis, nobody will hold antibiotics there. You will give antibiotics. But the main role of Procal is, I think, stopping antibiotics.
Correct. Your answer nailed it there. So stopping antibiotic, it has got a role. Starting antibiotic, because the subsequent question is also same. To increase in procalcitonin warrants any escalations of antibiotic.
No, I think the escalation of antibiotic really depends on the clinical picture, because I think the Procal also has a role in seeing your response to therapy, because if you started an antibiotic and then you find your Procal coming down, you're reassured. But I must be very frank, I have not really found Procal to be extremely useful in making decisions about antibiotic therapy. I rather go by other factors.
Okay, we can switch over to the antibiotics now. Person has taken amoxicillin clavulanic acid for the last 2 months, before last 2 months. So again, the person needs some antibiotic. Can we use the same antibiotic like amoxicillin can be reused within 2 months' time?
Yes, you can. It depends on what is the indication because we have to decide whether it's a respiratory indication, whether it's a GI indication. So I think it would depend on what is the indication.
They asked, or you mentioned about it there, but the person is not able to pick it up. Why cefixime is not a good choice for upper respiratory tract infections like pharyngitis, sinusitis?
Because it does not work for pneumococcus, which is the main causative bacterial cause of pharyngitis and uh, you know um, uh, sinusitis and otitis media. Doesn't cover pneumococcus.
Can be had azithromycin as an empirical therapy in inpatients pneumonia.
No, no, because as I said, there is a rising resistance in atypicals to macrolides.
In the same tone, why ciprofloxacin is not good for MSSA?
Because it's not a good drug at all. It's not an MSSA drug at all. It will lead to increasing resistance. So there's no role of ciprofloxacin in treatment of MSSA infections.
One of the common questions that general practitioners as well as hospitalists face a difficulty, antibiotic test dose. What is your
There
policy?
is no role of any antibiotic test dose with the exception of for benzyl penicillin. And again, we don't have that benzyl polylysine which is used for test dose. So no role of antibiotic test dose at all.
Dose of cefixime 400 milligram or 600 milligram for the enteric fever.
600 milligram twice a day.
Should we monitor the serum levels of patients started on vancomycin?
So vancomycin serum levels are indicated in certain situations, patients with serious MRSA, patients with renal failure, patients with rapidly changing creatinine clearance, patients with infective endocarditis. Yes, you should do. Actually, now they say that you should monitor both trough and peak levels and use the AUC over MIC calculator, dosing calculator. Yes.
What are all the safer antibiotics in pregnancy?
So, most antibiotics are safe with the exception of aminoglycosides. Aminoglycosides should not be used in pregnancy. Doxycycline maybe should not be used. Tetracycline should not be used.
Which empiric antibiotic should be started in patients with suspected CRBSI?
So it depends on what is the cause of CRBSI in your unit. So if your ICU has, most of the ICUs right now have gram negative cause of CRBSI. So it depends if you're, and what is the rate of carbapenem resistance in your unit. So for example, if your unit has mainly Klebsiella and CR Klebsiella as a cause of CRBSI, you would give Casaviastronam.
Treatment of ceftriaxone resistant Salmonella typhi.
It would be meropenem.
Does in vancomycin cover MSSA also, ma'am? Why you had MSSA antibiotic also?
No, vancomycin is poor for MSSA. So studies have shown that the mortality was higher in patients of MSSA which were treated with vancomycin. So it's not a good choice for MSSA. But I was saying that when you have staph aureus infection where you don't know whether it is MSSA or MRSA, then you may have to start with dual therapy till you figure out what is the sensitivity of the MSSA, of the staph aureus.
In similar line, when comparing linezolid and clindamycin, which one you would prefer as an adjuvant therapy in managing staph aureus and group A streptococcal skin and soft tissue?
So assuming that you want to give it as an antitoxin drug, then you could use either. The only issue is that there is a rising clindamycin resistance. So if you have a patient with a streptococcal toxic shock syndrome, you may want to use linezolid, but we generally use clindamycin.
Antibiotic with steroid, good or bad?
I think that's a very vague question. You may have to use steroid only in very specific situations, like you have septic shock. You may have to use hydrocortisone, or in patients with community acquired pneumonia, there's a certain subset. You may have to use steroids.
Emphysematous pyelonephritis without bacteremia, antibiotic of choice.
I would use meropenem because these are patients who would have either E. coli or Klebsiella. So it's definitely a severe infection, meropenem.
How to use narrow spectrum antibiotic as resistance is already developed for many of them in current scenario.
But again, it would depend on the clinical setting. For example, I told you it depends on the clinical setting, whether
Okay.
you are practicing in OPD or IPD, and what is your syndrome and what is the likely pathogen.
What is the actual spectrum of coverage of ferropenum?
Faropenem, unfortunately, was developed in Japan as a respiratory antibiotic, mainly for respiratory pathogens. And they, on some studies, found that it also has activity against ESBL. But the problem is that it doesn't, there is no way of susceptibility testing. So there is no susceptibility testing available. So that is why, how do you use it for a UTI, ESBL UTI? That's the problem.
In carbapenem resistant GNB, what is your first choice? Polymyxins or Casavi?
It depends on what GNB is it. Is it Enterobacterales or is it Acinetobacter or Pseudomonas? So if it is Enterobacterales, then we would use Cas-Avi plus Aztreonam.
Okay. Empirical oral antibiotic for prosthetic joint, culture negative.
Prosthetic joint, which is culture
Culture
negative.
negative, but we want empirical oral antibiotics.
Oral antibiotics. I mean, I would not give oral antibiotics to this patient. I would give probably Merovanco to this patient or Merotico, because it would be gram negative, gram positive or something. So we would give 6 weeks.
Ma'am's word
Or
about
Merolinizolid.
biapinum. What's about?
Sorry,
You talked about ferropenum, now they're talking about biapinum.
I have no idea about biopenem. Sorry.
Can we use phosphomycin other than urinary tract infections?
Yes, so it can be used. IV phosphomycin is good for E. coli bacteremia. I mean, we have used it as monotherapy as well, and it has worked well. So it's a good drug for E. coli, IV phosphomycin, especially in pediatrics, neonates, and it has excellent CNS penetration. So it's a good drug for CNS infections.
Ceftriaxone 2 grams OD is good or 1 gram BD is good?
It depends on what infection you're treating. So if you're treating pneumonia, you can use 1 gram BD. But if you're using enteric fever, you need to give 2 gram BD. If you're using meningitis, you need to give 2 gram BD. If you're treating infective endocarditis, you can give 2 gram OD, and that's fine.
Which glycopeptide is better in managing soft tissue infections, Tico or Vanco?
I would use ticoplanin because can be given as once a day OPAT.
Indications of sulbactam and GNB dose.
So sulbactam is used in Acinetobacter, and the dose would be about 6 to 8 grams per day as an adjunct drug to polymyxin.
For cystitis, what is your preference? Phosphomycin single dose or nitrofurantoin?
I would use nitrofurantoin if it is sensitive because I would reserve phosphomycin.
For antibiotic or choice in VAP in your hospital?
In
VAP, ventilator-associated pneumonia.
It depends on the susceptibility. In our hospital, most of it is due to Acinetobacter, and it's very challenging to treat because what drug do we use with polymyxin? Most of the other tigecycline, minocycline are resistant. So we use polymyxin with maybe sulbactam.
Treatment of recurrent UTI?
Treat the cause, what is causing the recurrent UTI, and put them on prophylaxis if possible. I think these patients need urologic studies. They need all those urodynamic drugs like urotone and all those stuff. That is the issue. Most of them.
Dosage of phosphomycin for other infections apart from UTI?
So again, it is basically 16 grams per day, 4 grams 6 hourly IV.
Okay. Some physicians, okay, the surgery has I think you have answered most of the things so far. So I sincerely thank for your time as well as dedicated sessions. Most of the people wanted your PPT to be shared.
You can share it. You can share my PPT with the
Okay.
audience. No
Okay.
problem. Yes.
So that's the excellent. Last time.
I will email my PPT to you, Dr. Suresh.
Sure. So to make it short, because people want to know little bit things, last part of our presentation is a couple of things there. One, people want to know the antibiotic spectrum. Dr. Tanu wanted to have syndromic specific. So this is a simple card. You can keep it in your desktop to decide which antibiotic for what bacteria. You can have some simple, this is called rule of thumb thing there. So you can keep in your practice. This is going to help people who just learned one sessions of antibiotic. This is going to help you out there. We are
That's very nice. Yeah.
lot of materials we are going to provide because we know this is very difficult to grasp all antibiotics related thing in 40 minutes discussion there. So we are providing the participants a lot of materials to you. That don't worry about it. And simple things also we put. What is gram positive agents? What is gram negative agents? You can divide also. This is some overlap will be there. Keep in mind some overlap will be there. So just what are the things you need to know? We just put it in a simple thing. To start with the things, these things can have it. Both gram positive, gram negative, and anaerobic covers, we are just putting it. Some antibiotic will miss out. This is in gross what you are using in a day-to-day, day in and day out practice. And we need to know what is the differences between Cipro, Levo. Don't think all fluoroquinolones or all antibiotic is same in particular group. There is a minor differences. So don't think Cipro is equal to moxifloxacin, Moxi is equal to Levo. Don't consider. Similarly for other groups also, Doxy, tigecycline, minocycline, minor differences are there. So we need to think about the minor differences. This point Dr. Tanu clearly pointed out, depending upon the concentrations. Even for the upper respiratory tract, he told about sufixim, ciprodoxim, the levels is not that great. Similarly, ampicillin, amoxicillin are both good, but penetrations of amoxiclav into the brain is not great compared to ampicillin. Similarly, for UTI, nitrofurantoin is a good for cystitis, not a good drug for pyelonephritis. This is called pharmacokinetics, pharmacodynamic. Maybe in the lab that drug will work, but in real life it won't work. Keep in mind. And we need to know she's a pediatrician. All pediatricians are good. They will always start milligram per kilogram. Adult physician use standard doses. That's a problem. For example, she clearly told cefixime go with 600 milligram BD, but people are using 200. In fact, getting a 400 milligram tablet of cefixime is a bit challenging for us. We are using 200 milligram, 2 or 3 tablets. That's a big problem we are facing. So use maximum dose. We didn't told. Alexander Fleming in the lecture, he told use a maximum dose. Like a pediatrician, they put milligram per kilogram, calculate mg per kg. That's more important. And nowadays, short is sweet, and oral is equal to IV is coming up. But even then, for example, prosthetic joint infections and endocarditis, some amount of IV is needed before converting into oral form. Straight away, don't jump. Some amount of IV is needed before starting oral antibiotic. Couple of trials are emerging, but none of the trials says from day one is required. For other infections, mild infection is possible. Good bioavailability, you can try that one. That is also possible. Those interested to learn more things, we have keep providing the data for you. So this is a scan code. You can join the group and you can have the other CMEs is coming up. Next week, we have completed one session of introduction to the infectious disease topic. We are going to put some of the cases as well as some of the practical points we are going to discuss next week. And I thank sincerely the ICP and APA for giving this wonderful opportunity. And I thank Dr. Tanu, despite a busy schedule, despite keep on asking there, so she has keep her time today and spend her 1 hour time there. Thank you, Tanu, for your wonderful presentations and clarifying almost all. This is a maximum number of questions I received there. In fact, I didn't pick some of the questions also. Maybe in the chat bot, I'll put it a little later for you. I sincerely thank, and please, participants, mute yourself because it causes some disturbances to the speaker. It's not intentional, but please keep your muted yourselves. And whatever questions and whatever things you want, please put it in the chat box in Advantage itself. We created a WhatsApp group. Put it in the WhatsApp group so we can choose your topic speakers also. If you want to suggest, please feel free to do it there. So we can bring whatever speakers and whatever topics you want. So this essentiality, this short certificate course of 20 to 22 weeks, you need to go through the essentials of infectious disease. Not all the things, at least essentials of infectious disease you need to learn. That's a basic idea. I thank, because we overshot 4 minutes, I thank all the participants as well as the IT team for providing the support. Thank you very much. Thank you. Good night. We can exit.